Hello, everyone. My name is Andrew Blustein, and I am the chairman of Garfunkel Wild. We are very excited today for a couple of reasons, not the least of which is this is the first time I've worn a tie and a jacket in like 3 years. But a lot of times my ASC clients, administrators will call me up and said, have you heard anyone having this problem or that problem? And hearing it so often, I thought it would be really good to have a session where we talked about this kind of in a group setting. I think a lot of us are experiencing, a lot of administrators are experiencing the same issues. And I thought it would be really interesting to get people spread out from different locations and states to get a sense of camaraderie and solution building. And if this works, and I know a lot of you have signed up specifically for this session, we're going to make this a feature of future years. So the speakers will be on at 3:30. So feel free, that will be live. So feel free to get on. I likely will be wearing a different tie. And you can ask them whatever questions that you have, because obviously as we're doing this recorded session, you can't ask questions. And not just ask questions, but if you have solutions to some of the problems, that would be great. Okay, so we have a really good panel. I will do the introductions. Looking at their accomplishments, I feel completely inadequate, but the first person up is Lillian Carson, who's the Vice President of ASC Development and Clinical Operations for Virtua Health. Lillian has over 30 years of experience in both clinical and management operations and strategic development. She's in charge of ASCs for Virtua throughout the state of New Jersey, as well as Pennsylvania and Delaware. She's dealing with regulatory, credentialing, clinical bylaw, everything you could imagine in an ASC that's going on. She was previously the AVP for Surgical Services, where she worked on standardizing operations and doing a whole bunch of things. Prior to joining Virtua, she was at Area Health, Jefferson Health, as Vice President of Procedural Services. She also spent time at CHOPE and Jefferson in both surgical services and patient care. She's an RN. She has certification in perioperative nursing and first assistant. She's also a surveyor for the American Association for Accreditation of Ambulatory Surgery Facilities and CMS. And I don't know how she finds time to do all these things, but she also has 3 children. So next up, we have Nicole, who's the Senior Vice President of Operations, Quality, and Patient Care Outcomes for Constitution Surgery Centers. Nicole does a lot for CSA, and including developing a resource for physicians and healthcare systems to make ASCs more efficient and higher quality. And her territory is everywhere where CSA is, Northeast Pennsylvania and Virginia, and as well as other centers that are under development. Her specific area is Southern Massachusetts and Rhode Island, and she is working at the Surgery Center of Rhode Island in Warwick, Rhode Island, and East Bay Surgery Center in, I know I'm going to get this wrong, Swansea. Did I get that
Swansea.
Right?
Swansea.
That too. I'm a New Yorker, so I know Queens, and that's it. Massachusetts. She is also previously she was with the Midtown Surgery Center in Manhattan, and she worked also as an administrator at a center in Westchester. She is a nurse from that had been at NYU, as well as a master's in public health from Columbia. I'm feeling completely like I didn't achieve, but okay. And then we have, last but not least, Monica Ziegler, Chief Operating Officer. Actually, it says Chief Executive Officer. Is it Chief Executive Officer? Operating. Okay. For Ambulatory Surgery Centers of America. And she has an incredible background as well in managing both hospitals and ASCs. And she specializes in turnaround. And I knew her as an administrator at the Manhattan Surgery Center, which is in Manhattan. That's why it's called the Manhattan Surgery Center. And she served the Pennsylvania State ASC Association as a vice president and presidential roles for over 10 years. And she's a national speaker. So that is a serious panel. And let's get right into it. So, Lillian, let's start with you. What do you think is the biggest or a big issue that is facing ASCs right now?
Sure. So, Andrew, I think, we need to acknowledge that, we're at the hopefully tail end of the pandemic. And that certainly has affected us since the beginning of March in 2020. So there's many issues that we've all had to face. But I think probably right now and throughout the pandemic, staffing has been our biggest challenge. And if you think about how we did business prior to the pandemic, and how we did our staffing issues, they're totally different now than anything we've seen prior. If you think about what everyone went through, being furloughed, then coming back, deciding if they wanted to come back, illness, and then dealing with all the processes that we've had to put in place, it's really been a challenge to recruit and maintain our staff and the right staff.
Nicole, would you agree that that's the number one issue right now?
I would. I would agree that staffing is probably the most significant challenges amongst other, as mentioned earlier. Just even in the number of candidates that we have applying for positions is a quarter of what they were prior to COVID. And then the number of no-shows for interviews where the candidates who decline positions based on their compensation has been astounding and something that we never really saw pre-COVID. We've also extended offers to employees who really were just using our interview process and our offering stages as bargaining tools to increase their pay at their current workforce. And then they go on eventually to decline the role. And then on the clinician side, we see them, especially RNs, leaving the workforce at an alarming rate. Many are retiring or leaving the workforce for remote work and travel positions. And then on the flip side of that, for the nursing education side, we're seeing a significant lack of nursing educators that are even available to prepare new nurses for hire. So challenging really soup to nuts across the board.
So one of my mentors once said that you can't fix a problem until you understand the reason. So Monica, assuming that your centers are experiencing the same problem, why do you think this is? Like what's it's probably not a thing, but what are some of the things do you think are giving rise to this?
I think, first of all, we have a little bit of the PTSD going on from nurses that were in hospitals that now want to come to a surgery center in some cases. And when they get there, they are finding, oh, it's still kind of hard work here. Like, I can't just relax. So there is that imaginary thought process that they would come to the surgery center and find some utopia vacation and still be working. I do believe that the pandemic is certainly responsible for some of the staffing crises that we see. And it is reflective in, as we talked the other day, staff tolerance. of each other, of their managers, of the physicians. And when I say that, I use the example that if a new manager says to the staff person, could you go and get this? Could you go do this? Or I need you to do this. And they don't say, please, could you go get that? And thank you very much for doing it. The staff expectations are much higher. And if they are annoyed by that, there's nothing holding them there. So they will be quick to jump the fence and go someplace else. We're also faced with because the hospitals are so short-staffed because they experience so much trauma amidst the pandemic. Their salaries are going up. And we are now trying to compete with these hospitals that are paying $60 an hour or 100% bonuses that I've heard of in my Lehigh Valley, Pennsylvania, where I live. There's just incredible factors or incredible offers that people are putting out there to attract staff because they don't know what else to do. And I thought it was quite interesting this weekend. I was reading an article in a magazine, and it's not just healthcare, of course, we all knew that, but it was about restaurants and their waiters and the people that are serving their customers. And the article is saying, please be nice to our waiters. Please be nice to our servers. Please tip them well. We can't say, oh, please tip the nurses well because they're working really hard and they're stressed. But there is a factor in there of that waiter, that nurse. If you growl at them and you are just miserable to them, whereas before they needed their job and they're going to stay, now they're quick to say, I can't do this. I just can't do this. And they walk away.
Right. By the way, it's true in law too. Lawyers are the same way for that. But let me ask you all kind of a prediction question, so you can't be wrong. It's where you are now. Next year we play this back, we'll see. Is this the kind of thing, so COVID goes down to a bad memory, people take extra long vacations, is it going to right itself, or is some of these trends, are they here to stay? Can you give me a prediction?
You want Lily? You want to go?
Anyone? Yeah.
I think that the processes we have in place right now in our ambulatory surgery centers will be here for quite a while. I also think that many people, and we talked about this the other day, many people did take that step back, and depending on what happened to them, whether it was illness, someone close to them or themselves, or just seeing what some of our colleagues have gone through, did go through a paradigm shift and, reevaluated what they're doing. So as far as staffing, I think we have to do things a little differently. And, we see it in the numbers, we see the numbers rising. So we know that as numbers of cases, sorry, I should clarify, in our centers are, the cases are increasing because of need from our patients. So I do think that, we will get back to where we were pre-COVID. But I don't think that a lot of processes that we've put in place, I don't think will go away. And we've learned from it too, right? We're a little smarter how we do things. Things that are so obvious to us now weren't back in March of 2020.
Mm-hmm. So,
Monica, I'm sorry.
Yeah. Monica, you want to say something?
I think that Lillian started to speak or came close to addressing some of the ways that we look at even our models of nursing are going to change again.
Okay.
And back in 1985 was when primary nursing came into play, and there were second generation and on and on and on. And it was really the environment and the demand for nurses at that point in time that was changing the way that we delivered care. And we are seeing exactly the same thing, even at the ambulatory surgery center level. We are now looking at, does a nurse need to do this? Can a medical assistant or a patient care assistant do this? And if it's something that can be done by someone else, then that little piece should be done by someone else so that I can reserve the nurse resources for the nursing tasks that need to be done so that they can really, really focus on care. So some of the pieces that come out may not be bad things.
Right. I agree.
Good thing for the future. I want my nurses to think like nurses and to do nursing things.
Nicole, do you agree with that?
Yeah, I absolutely. We had a historically very heavy RN based model. I think at all locations, that was just sort of the way that we always did things. And we were, the COVID pandemic, and I think the increased workload for the RNs, and we're talking about, the additional patient swabbing that we had to do. All these patients needed to be called for COVID appointments. We needed increased screening. So it was sort of by force of nature that we had to look at the way we worked a little bit differently. And for the first time, we have CNAs and medical assistants in-house who are helping us to keep up with that throughput. And I don't think that measures like that are necessarily going to take a step back.
But is there a concern that some people who are not RNs may start to do things that are a little beyond them, beyond their licensure, is really what I mean?
I think you need to look at the scope of practice in each state for sure. That's number one. But we were having nurses do everything from helping patients change to getting crackers after surgery to doing a simple set of vital signs. All of that is within the scope of practice of a medical assistant or a CNA. So I think it's just utilizing our own resources smarter.
Right.
I think it was evident to your point, Nicole. You mentioned about when patients are changing. Nationally, we saw an uptake in the incidence of falls within our centers. And if you think about it, we didn't have anyone at the bedside with the patient, their significant other or loved ones or whoever. And, so we saw that uptake in falls and had to repurpose or redo our processes of how patients get dressed. And depending on the mix in your center, that really pulled our nurses back to staying with the patients, doing tasks like getting dressed. And, in an already environment where we added processes and added time, how long it took, how long your day is, we're finding that isn't the best use of an RN's time, to your point.
Okay, but let me take you back before we leave that topic entirely. I can hear an administrator out there in TV land saying, okay, that's all well and good. I hear you. But I have a shortage right now. Is there anything I can do to get people? And second of all, kind of related to that, the people I do have are fraying at the edges, right? How do I deal with their mental health so that I don't have a problem that I'm down 3 techs and now I'm down 6 techs before I turn around? Any thoughts about, maybe we'll start with you, Nicole, again, because you outlined so well before all the problems. How can I fight that?
Yeah, it's difficult. Mental health is just across the board, not just with our own staff, but nationwide, worldwide, is in a crisis right now. And it's not just one single thing. It's one thing locally at your place of employment to be dealing with the issues going on there, but it's certainly intensified when, you feel like your personal life and the world around you seems to be turned upside down. So we're seeing, high depression and anxiety rates, not only in ourselves, but in our children and the general community. So I think it comes down to tolerance at some level and flexibility on the employer's part. Historically, if you had to call in sick because your kids were sick at home or they couldn't go to school, there was less of an understanding about that than there is now. I mean, now you're doing it because it's the right thing to do. And I think that taking that added level of stress that, oh no, I have to call my employer and tell them that now my child is sick, they have to stay home, they're under quarantine, taking that little bit off their plate, allows them to balance that a little bit more effectively.
Monica?
I think that each center has to assess their center as an individual unit, because what's right for one center is different for another center, is different for another center. So I've recently had a center where their RN aggregate of nursing salaries were too low. Flat out, they were too low. So in order to recruit within their environment, they needed to, across the board, do a market adjustment on those nursing salaries. So we did do that so that we could compete with the local hospitals. But we did two things with it. And one, we looked at the model of nursing and what they were doing and what they didn't need to do and what someone else could do. So how could we decrease the cost? So if we're going to take nursing salaries up by a chunk of change, which we did, where can we save on some of the money elsewhere? And that's bringing in the ancillary kinds of personnel. The other thing that happened at that particular center was they tried the agency staff in their area. And when you take a group of physicians that are attached and love their staff and know how they work, and those staff know how the physicians work, it's a quick eye opener to see that they really, really value their own staff a whole lot. And that's not to say negative against the agency, but it's that those physicians began to value their staff, and they're much more protective, much more tolerant, much more, okay, well, maybe you didn't turn my room over in 3 minutes the way I expected. You know, it took you 5 minutes. Okay, I'm not going to complain because I don't want you to go anywhere because I really do value you.
Right.
So.
And what about, Lillian, what's your thought about like international nursing agencies or places like that? Are those useful?
I think Monica mentioned it. We have looked at agencies. I have not looked personally at using international. I certainly think that we need to look at all options to help us. But getting back to something actually that Nicole and Monica mentioned is, and certainly the financials play a big part in it, a big part in employees' choices, but it's really about the environment and how the leadership there value those employees, including the physicians. And so I think, you know, pay and environment are a huge factor in retaining and recruiting. But the international, I don't have any experience with. I don't know if Monica or Nicole do.
Do either of you have?
I did years and years and years ago, back in the late 90s, early 2000s. And it was a very, very difficult task at that point. That was when the nursing crisis was very much in the hospital settings, and the hospitals would go to different countries and try to recruit. And when they brought people back, they found that the language barriers were very, very great. It was such a huge challenge that it frustrated everyone, the poor people that came and also the people that were trying to invite them in. And so I think that at that point in time, it just limited itself because it took too long to acclimate them to the environment and to help them over the language barriers.
Right. So Lillian mentioned before leadership, but aren't there also, I mean, and we've been really focusing on what I call frontline shortages, but are there also shortages at the leadership levels at ASCs?
Huge. That is, you know, leadership, in my opinion, really is what makes the ASCs function well. And the administrators, the director of nursing, and the business office manager, along with the medical director. To me, that's your core leadership that sets the tone, that really looks at efficiencies, looks at all the factors that you're looking at. And we've had a really tough time, I can tell you, and recruiting for those key positions. In particular, the director of nursing really tough to find the right folks out there. I think Nicole mentioned that even when you find some candidates, there's a no-show or they change their mind. They don't even go through the interview process.
Yeah, we're seeing that too. At one particular facility, we knew we had a pending retirement in December for a director of nursing position. So I sat with my administrator and we said, what's a reasonable timeframe that we think to post this position, understanding what the workplace is like right now, and that it would take them additional time. So we thought 6 to 8 months was reasonable. And now we're coming up on October and we're still, that position is going to be vacant, and we're looking how we're going to disseminate it among several other employees who are currently there. There's just a lot of opportunity, I think, for people at that leadership level too. And for better or for worse, it's just tough to get people in those roles within the ASC.
Right. And it really affects of your tour, not just the clinical day-to-day, but the front of the office, the front of the center too, your business office, right? If you don't have the right folks in the right positions, your AR starts lagging. You don't make collections, all the things that you need to do to keep the operations running.
And it sounds like you're in a catch-22. If you promote some of your RNs to positions in leadership, then you don't have them to do the frontline stuff. So it sounds like a problem. But let me come back to, as we're coming into year end, this is kind of come out of an oddball one, but I got a call on Friday from an administrator asking me what other ASCs are doing, what I thought about holiday party. Something we at our firm are thinking about. I mean, it helps with the stress levels, I suppose, but maybe not. What are you guys thinking? You can have holiday parties? By a holiday party, I mean everyone's in a room together, not on a virtual thing. Nicole?
At one of our locations, we are having a holiday party. It was brought forth to the board at our last meeting, and they did approve that. Everyone is required to be vaccinated, and any +1s have to show a proof of vaccination upon entry. And obviously, we're going to abide by whatever state regulatory guidelines are in place for social gatherings, as well as whatever the facility itself has in place.
Sounds like a hell of a time. It's going to be a great party. Monica, what are your places doing?
Well, again, I think it's very center specific, and in Manhattan, we certainly struggled with that, and we were just tight as drums. We did not have parties the way that we used to. We had some parties in the park. The staff probably are still having some in their sweatshirts now, because they appreciated gathering together. But I also think that people are torn because COVID taught you that there's more to life than just working, and that family time is really valued, and there are a few minutes that they're not at work, they want to spend with their family. So as much as I think it's a good camaraderie kind of thing, and it'll be great for maybe 70% of your staff, there is a chunk of staff that really just wants to get home to their family and can't wait to be with them, and their responsibilities there are great. So you have to make them feel valued when they're there, I think.
So, but Monica, are you saying that they might be at the holiday party thinking, well, let's say Nicole's holiday party, wearing a mask with your vaccination cards, thinking, I might not want to be here, I might want to be home with this precious time?
I think some people will think like that, yes.
Yeah, okay.
I think that they now value their family. I mean, we had staff that lost family members due to COVID. We had staff that had COVID pretty severely, and that's really heartbreaking. When I call a nurse every day to make sure that she's okay and that she's going to go to the hospital if I think that she needs to because she is trying to avoid it so badly, that speaks to something. That's pain that people felt. So that affects their lives and the choices that they make over the holidays. And they didn't get to see their family last year, so oh my gosh.
I hear you. So maybe they'll give up on that little pig in a blanket for this holiday party. Yeah.
They're the best though.
Yeah, they are. But you can't eat one. That's the problem. So,
Right.
so one more question, then we'll move to operations. Are we offering support for these stressed out leaders and frontline people, employee assistance programs, anything like that we're making available? Lillian, Nicole?
So one of the things I think is key, especially for our leaders, is that they know they're not out there alone, that they know that there is someone, a resource. And so one of the things that, and I have a wonderful team that I work with that actually go into the centers, spend time with the administrators or the director of nursing or whoever, needs the time. It's mostly the administrators, and gives them a chance to talk through things, gives them a chance to maybe have a different perspective of how to do things. When you were mentioning the holiday parties, and I have not, as of mid-October, supported holiday parties, just knowing that that every day there are patients still being admitted to hospitals that are COVID positive, including vaccinated patients. So I haven't supported it, but I think it's really needed. But it makes us think about how can we make them appreciate it, to Monica's point, in a different way. If we can't have our usual 100 people in a room, everybody's talking in each other's face, drinking, having a good time, eating. What can we put in place to make them know how appreciated they are and what a valuable asset they really truly are to our centers?
When you say that, are you talking, is there something other than money that comes to mind?
I think it's not just money, it's environment. It's, just the way that we all lead and get through these times together. And I think because you spend such a big chunk of your life at work, time-wise, that's probably more important, actually, than money. And, I know that the centers that really feel supported by their leaders have gotten through this much easier than the centers that have doubt or questions.
Interesting. Monica, you wanted to say something?
Right. A couple of things come to mind. Pizza goes a long way every day, almost. It really does. They're busy. They love to walk into the lounge and have 10 boxes of pizzas there. That's always great. To your point, Andrew, you said about having a remote, a virtual kind of meeting. We did do that during the deepest of COVID. We had cocktail Fridays, and we all got together on cocktail Fridays. There weren't a lot of people, but those that could dialed in. But for me, as the administrator at that point in time, because I was still in the administrator role, I would have to say that the state association was a really, really good help to me. They were a really supportive group in that every Thursday or every maybe Friday, we had a call, and there were however many state association administrators on that call. And we're doing exactly what we're doing now. And it was so helpful. It was so helpful to hear that, oh my God, the Department of Health went and took their vaccines back. They delivered them and then they took them back, or they did this or they did that. It helped me as an administrator. And just by what you were just saying, it gave me the idea, we're all in COO, vice president positions. I think I'm going to start a support group for my administrators, and we're going to do a virtual call, not just me and the administrator on the call every Monday saying, hey, how are you? What are your numbers like? I'm going to say, I want you to meet you and you and you and you and you, so that because that was really, really helpful to me. Somebody else needed to share my pain, and they did.
That's right. I think I've told my partners and associates that we all have to work harder at being connected and not losing our humanness. It's very hard. And Zoom only goes so far. All right, let's go to operations. Nicole, so we always had infections even before COVID, right? What are we doing now differently, or maybe with a more concentration? And do you think we're going to continue to do it even as hopefully COVID wanes?
Yeah, so infection control, I think at the ASC level has always been super important to us. I think that the difference between the types of infection control we're doing now, what we used to do, is that a lot of it was quote unquote behind the scenes before. And now it's very visible to our patient population. So masking, social distancing, hand hygiene, all the things that we've increased or added to our infection control protocols over the course of the last year is very visible to our patient population, and they comment on it. Never before COVID did I hear someone in a patient satisfaction comment discuss the hand hygiene that was performed prior to the surgeon marking them in the bay. But all this stuff is so in the forefront that it's definitely very visible. And I think we're all better off for that. I think that the more that patients are knowledgeable of just basic infection control practices, the better off they will be moving forward.
Interesting.
Mhm.
Lillian, you were going to say something like that?
I agree with what Nicole's saying. I think patients look now for certain things to be in place more so than they ever have. You know, we screen them, we take their temperature, we ask them to attest to being vaccinated or the measures that they put in place, you know, prior to coming to the center. And I don't get that feedback negatively in our patient satisfactions, you know, surveys at all. I think that they feel safe. I think patients know that we're putting all this in place for their safety. I had to be a patient myself during the pandemic, and you know, it's something that you don't want to do unless you absolutely have to. But I certainly felt safe where I went. I felt like that everyone cared about all those measures.
Great. And what about, you mentioned before, I'll stay with you, Lillian, for a second. You mentioned before about falls.
Mhm.
That makes me think about, what are we doing with escorts and social distancing and those kinds of things, and good or bad? What's your thought? We'll stay with you on that.
So right now, I know the centers that I oversee, Pennsylvania, New Jersey, and Delaware, we have not put back into place that visitors can be with those patients unless, you know, they're minor, or they, you know, pediatric patients, or they have a mental challenge and they need that assistance. So we haven't put that back in place yet. And actually things have worked well with having patients get the instructions over the phone. They're waiting in their cars. Now, some of the weather changes certainly have challenged that process. But we haven't put it back in place yet. But I know that in different settings now, they're starting to allow visitors, especially the inpatient setting.
Has anyone put it back?
We have, and it's definitely facility by facility. You need to look at your actual physical facility constraints. I think that's certainly part of it. The waiting room, we're still restricting visitors. I think that that's probably our most challenging area, just given the patient throughput that we see in a day when you have 60 to 70 patients, and the time frame for which they need to be there, and to add a +1 or +2 to that would be extremely challenging to maintain your social distance. But we did start to allow escorts back into the PACU area to review discharge instructions. And we did find it helpful in increasing our patient experience scores, particularly in the communication domains around discharge instructions.
Interesting. And Monica, do you think are there any positives to having lack of escorts?
There are a lot of positives, because when you complicate your numbers with family members that are as stressed out as the patients, sometimes you spend a lot of times managing the family. So I think that we didn't experience the increase in falls, thank goodness. But I do believe it made us more efficient, because when you zone in on the patient, you're zoned in on the patient, and that's the only person that you have to worry about. And we call the family member ahead of time and say, okay, we're going to bring Susie out for pickup now. And we take Susie down and do our thing. And it's been a very efficient process from that way.
Interesting. And testing / making sure docs and staff are vaccinated. Well, that's too much of a combination. Let's take.
That's your job. You're the lawyer.
Yeah. Well, let's take. It's amazing the wars that are going on between vaccinated crews and unvaccinated crews. Are you having those tensions in the centers? Anyone?
We took care of it right out of the
Yeah.
gate, as you know, because we called you first.
Good move. By the way, everyone should do that, but keep going.
Yes, if I didn't call him, he'd say, why didn't you call me?
Exactly.
We
You made everyone
mandated
get vaccinated.
We wanted to be able to say to our patients that the staff were 100% vaccinated, that they were 100% safe, that this was the safest place that they could come. Now, again, every center is a little different. Now I have other centers that didn't do that, and they are faced with challenges. They're faced with physicians that don't want to, or staff that don't want to, and how are they going to do it in their environment? And they have probably a couple weeks to make those decisions, and then they'll have to face them. But where we did mandate it, everybody's just pleased as punch. And the doctors were like, oh, my patients were so worried, and I'm so glad we did this. And it was just needed.
Yeah. In Rhode Island, it was an executive order that was effective October 1st, and it definitely made the conversation easier. I mean, it is what it is. The state says that you can't be in the building if you're unvaccinated after October 1st. So that sort of took the guesswork out of it, but it is definitely center by center. I think the flip side of that is that you're already challenged for staff. So what does that look like post perhaps CMS mandate, and how are you going to backfill those roles?
Right.
Right.
You want to say something, Lillian?
Well, yeah, I was going to say that in New Jersey, Pennsylvania, and Delaware, it was not mandated that the ASCs had to, everyone had to be vaccinated, and we are looking at it center by center. I have had a couple issues with employees or physicians concerned about being in the break room with employees or, other staff that aren't vaccinated, even though everyone's wearing PPE, or even in the room. And one of the things, though, that those 3 states did mandate is if you're not vaccinated, then you have to be tested at a regular interval, which depends on the Cali score, depends on the color, of the areas. Right now, it's a minimal of once a week. So we had some pushback with that as well, as far as, so if you're not vaccinated, you have to be tested. And there's a lot of logistics we had to work out with that, with employees. Patients need to prove a vaccination or be tested. It used to be that all patients were tested until, the vaccination rate started to increase.
So it sounds like it's getting more, we're beyond more accepted. It's just part of the culture now. Test for those who are not vaccinated.
It is an expectation, yes.
Yeah. Okay, so driving in this morning, thinking about this conference, I heard that there's going to be shortages of rubber now, and might not be able to get tires. So like, as those things couldn't get hard enough. What kind of supply issues are you seeing, or are you seeing nothing? I'll start with you, Nicole.
Yeah, so initially, it was obviously very PPE focused because everybody needed PPE, and we were really concerned about how we're going to require it, what we had in stock, and how we were going to continue to protect our staff and our employees. Now we're seeing things like medication shortages, commonly used items like ChloraPrep. there was a big back order on instrument manufacturing. So we're looking to roll out a few new service lines at one facility, and the time frame has been significantly pushed just due to availability of either a new supply we're trying to bring in that wasn't historically in our allocation, or instruments. So that certainly changes the tempo of operations differently than it would have before.
Yeah.
Lillian, you're finding that too?
Yeah, PPE certainly, was on the top of the list. Cleaning supplies, getting what you usually use. We've had to improvise, finding the right ingredients for what you have to clean the areas with, PPE, and as well as some of the things that you have to use in central sterile processing area. Blue wraps were on a back order. And then everyone has to try to find alternatives, and they all have little nuances of how long they're sterile, or what is it, event or date related. So it's constantly looking at those changes and making those changes and making your staff aware of them as you've had to change, what supplies you're using.
So,
And
go ahead, Monica. Oh, Nicole.
I was just going to say, and shipping and transport. I mean, we see it, ordering an Amazon Prime practice, package. We're seeing the same thing with medical supplies, where there's just a lack of people to actually deliver the supplies. Things that are supposed to be, first overnight are coming 2, 3, 4 days later. So it's really hard to anticipate.
And Monica, I assume you're experiencing the same. Are the doctors getting less picky, or that's the thing I want and I won't take anything less? Or are they starting to realize?
Well, sometimes they don't have a choice. And we talked the other day, and my dog just now found a squeaky. So get ready. Here it goes. Yes. So sorry. He's not barking though. The surgical caps was the funniest thing, because
right.
we got down to these hairnet things that are just hideous. They look like you. I'm so sorry. I'm gonna try to put him outside.
One of those commercials that you see about Zoom calls, right?
Oh no!
Monica, I don't think it's your dog. I think it's you. I think
We almost made it.
Well, no, wait. I gotta do something with him.
It's okay.
Okay.
You take care of that. I'll pick on Nicole for another question.
Okay, do that.
Nicole, the physician recruitment, is it something that's still going on, or is it like that's a luxury we're not getting to right now?
No, I mean, as of late, yes, it's definitely picked back up. But in the midst of the pandemic, we weren't even sure what our current operations were going to look like. We had to delay the onboarding of several providers. So in certain service lines, especially in the state of Massachusetts, where we were operating under an executive order, I couldn't recruit any ophthalmologists because most of the ophthalmology volume was considered non-urgent. The same with some new GI providers we were looking to bring on. So it was very challenging at that point to be able to understand, what do operations look like? What rooms can I staff? What days are I operating, in order to be able to slide new providers into that? But it's definitely getting better, I would say, over the course of the last quarter or so.
Okay. Lillian, who should be recruiting, and are you finding that doctors maybe who weren't looking to join ASCs are, or are they just like staying with the hospitals? What are you experiencing on that?
So, being in the joint venture partnership model with our physicians and the ASCs, we actually have dedicated people, resources that are recruiting and are trying to coordinate the recruitment and service lines to get those physicians to our centers. And that takes the burden off the administrator who's trying to do everything. It's unrealistic, we found, that, everything that the administrators are trying to juggle, for them to also go out and find new physicians to join the center wasn't working the way that we needed to. And so we built those resources into our team, and it's really worked well. Actually, we've had quite a uptake in physician recruitment throughout this last year. And I do think that that's one of the reasons why. I think also the physicians took a look at everything that they had to do if they were working in the hospital or working at the center, and what made more sense for the patients that they were trying to take care of. What made more sense for them.
Right.
Um,
So you centralized the recruit. So you don't think that your average administrator should be doing the recruiting?
I think that they can, but I think we found that it's unrealistic to think that they can do it at a rate that we expect them to do everything else as well.
Right. Monica, you're shaking your head. You agree with that? You're on mute now, Monica. It's okay.
Sorry, he's not barking, so we're good. I'm in a critical discussion right now about that, and there it started. I might have to be one going outside. So what we found is, or what we might try something very different, because administrators do not have time to go out there and
Right.
pound the streets.
Yeah.
They can be kind when they're invited in. So if I am Dr. Jones and I say, hey, could Dr. Blustein come and try some cases here? We'll be happy to take him. And that administrator will be kind as punch, but they don't have time to go and find Dr. Blustein because they're busy. So one of the suggestions that came up is that we will offer to staff a finder's fee, and the parameters have not been developed yet. If they can recruit one of the physicians that they've worked with in the past that they know is kind of a freelance guy out there yet, or girl, to bring them into the center. And if they come and stay for 6 months and they're happy and the staff are still employed 6 months later, then the staff will get a finder's fee of $2,000, $3,000 or something, make it worth their while. So they go and find Dr. Blustein to bring him into our center. So.
That's interesting. I have to think about that one legally, but
I know.
I hear you. I applaud the sentiment, but I'm not sure we should talk. But okay, I'm watching the clock, so let me move on to kind of a grab bag of issues. So, Nicole, can you speak to what specialties are still down, or what specialties are climbing? What are you saying about that in terms of volume?
Yeah, so it's everything. The volume is very specialty specific, and I think throughout the 3 centers that I oversee, we do every single specialty that you could possibly think of. So I do have the benefit of that sort of experience. But something like orthopedics, we're seeing those numbers ramp up as high school and college sports and people are back out and active and participating in rec sports. We've seen the sports medicine side of things certainly begin to ramp up as total joints were put in the back burner during that sort of urgency stage that we were in back in the spring of last year. Those are coming back on the books. And then specialty lines such as GI for standard screening colonoscopies. Again, those are last to come back onto the table at the end of 2020. And we can't get enough screening colonoscopies in the block time that we have available. I mean, we're booking a good 6 months out.
Wow.
But then there are some specialties, for one example, pediatric ENT, that's still significantly affected. So those bread and butter cases, the tonsillectomies, the laryngotomy tube placements were virtually non-existent for a long time. Kids are remote learning, not getting sick, wearing masks. And even now in school, they're back in person, but still wearing masks. And you're just seeing the incidence of sick kids going down, less and less. So it's definitely specialty specific by center.
That's super interesting. Lillian and Monica, I see you're shaking your head. Yes, you agree with you're experiencing the same?
Yeah, I think orthopedic, spine, pain, those patients, their condition worsened with time. Those are the service lines that are really have taken off. GI is coming back now as well. But I agree with Nicole, ENT and in particular, the pediatric world is probably, we still see a decline.
Kids are not 100% vaccinated yet, so, it's going to take a while for that to come back just for that reason.
Right.
What we also found was with physician partners that retired, perhaps early due to COVID, that we're finding it hard to replace them. How do you replace good partners that left because they said, wow, this semi-retirement, this is for me, I'm done. I just have to stay here now. I'm not coming back. And we've had that. So,
I think it's very similar to a lot of industries. People tasted not working and it tasted good for, it's not just a vacation where you're coming back. They were out for, various times. Okay, so I'm going to come to the last thing. Somebody described to me working in an ASC, it's like fighting a war on like multiple fronts, and every day there's another front that opens up. Ransomware. Okay, everyone always talks about it, but I even read an article today, but I also saw last week, there are gangs out of China and Russia that are specifically attacking healthcare institutions. That is their number one target. And I saw a hospital where unfortunately the fetal monitors got seized and the baby died. Monica, is it still a big concern? What, if anything, are your places doing about it?
I think it will always be a concern. And we went to IT about 2 years ago. We had a different kind of assessment. And Lillian's going to talk about an assessment, but I needed to know that my IT was fail safe or whatever. And they told me now that no one could get in. And I kind of believe them because I have trouble getting in on many days. So, meaning there's so many sign-ins now and this and this and this. And now you have to have this little thing and this little thing. So, yes.
Okay, well, before I ask Lillian about that outside assessment, I'm going to, for your sake, say that's not a challenge to any hacker that's listening. I'm sure they could get in. Please don't try.
I'm sure they could. It's not a challenge to any hacker.
There's some 12-year-old in the middle of nowhere who's like, I'm going to try. No.
Right. It's me whining and saying, why do I have to have 4 different passwords just to get to my desktop?
Lillian, what are you doing in terms of assessment?
So every ASC is a separate individual entity, and they are not tied to the hospital. But so one of the safeguards that we put in place was every year we do have a third-party vendor that was vetted through, by our security expert to come in and do an IT risk assessment. And so they are separate than their own individual IT team. And the assessment is very detailed, and anything that hits, I'll call it the red, needs to be addressed immediately. And we bring those reports to the governing board at each of those centers. So it is performed annually. And all those reports go back to our Virtua security expert for review.
So I'll tell you that is super important. And I deal with breaches all the time with Office of Civil Rights. Annual assessments, at least, sure, almost every 2 years would be too late, but too many ASCs are not getting an assessment. They have a computer vendor who checks you, but an assessment has to go through all the HIPAA standards, say what each one is. They're expensive, but I can tell you that there's no way for me as an attorney to defend if you don't have it. You either have it or you don't. I can't say you kind of have it. You thought about having it. So I applaud that. Okay, so, well, we could do this for another hour, but we are out of time. So I want to thank so much the panelists. If you out there have questions at 3:30, we can take them. And guys, keep doing what you're doing. I know it's hard, but thank you very much for today and for everything you do. All right, be well.
Our pleasure.
Thank you for having us.
Inviting us. See you, Andrew.